यहीं से बैठ के कर लूँ?
हाँ हाँ, आप उधर से ही करें. Good morning, everyone. So today again we have a special lecture because biliary and pancreatic diseases form a major part of our clinical workload, and also for you, the students. In all likelihood, there will be a case related to biliary and pancreatic diseases. And today, we cannot manage a biliary or pancreatic disease without the help of therapeutic endoscopist, either as a part of preparation for surgery and in many cases as the definitive treatment. So I think as surgeons, we all need to know at least the basics of these endoscopic interventions. And I don't think there could be a better person than Dr. Saraswat to tell us and teach us about the principles and basics of endoscopic interventions. So over to Dr. Saraswat, who, as I informed you earlier, has recently joined us as the head of the Department of Hepatology at Mahatma Gandhi Medical College.
Sorry. Is that better? Am I audible now?
Yeah, audible now. Yes.
Okay. So, in brief, in the next 45 minutes or so, I'll try to talk to you about the history of this procedure of ERCP, which is about 50 years old now. The first procedure was done way back in 1968, and it has undergone rapid evolution over the last 3 or 4 decades. Briefly about what is the setup. Establishing, setting up an ERCP theater with the instruments, accessories that go with it is a large topic, and I'll only refer to it in passing. A word about indications, contraindications. This is a patient concept, consent and preparation for the procedure is a very important part of ERCP. But again, I may not be able to do much justice to it because of the constraints of time. We all need to know about the complications and the management of complications of ERCP, which are not insignificant, and the results we have. I'll briefly also talk about the techniques and the various procedures of sphincter of Oddi or papillary cannulation, sphincterotomy, biliary and pancreatic drainage, and stone extraction, and some general things about ERCP. So the first cannulation of the ampulla of Vater in a living patient was done by George McCune way back in 1968. And in these very early years with prototype endoscopes and limited instrumentation, the success rates of cannulation were not great. And as you would see in a series that was published around by George McCune at this time, less than half the time they could get into the duodenum, and only in about 25% was the pancreatic duct visualized. Simultaneously, work on this was going on in Japan, and the first series of 53 cases with about 77% successful cannulation was reported a year later by Oi et al. The era of therapeutic ERCP was launched in 1973, when within months of each other, Kawai in Kyoto in Japan and Klassen and Demling in Erlangen, a city in Germany, reported for the first time the procedure of endoscopic sphincterotomy. Subsequently, over the next few decades, from 80s to 90s, there has increasingly been an increase in the sophistication of the instrumentation, development of dedicated accessories, and a large number of endoscopists have moved into the field of therapeutic ERCP, with the result that there has been a shift trend. Many procedures which were earlier the domain of the surgeons, like for example, CBD clearance, removal of CBD stones, similarly, drainage of pancreatic fluid collections, today bile leaks, management of malignant biliary obstruction, palliative management of malignant biliary obstruction are now exclusively dealt with almost all over the world by ERCP and by endoscopists. The 90s and the 2000s saw improvement and standardization in training and competence assessment in ERCP as the procedure became more widely practiced. And there was a increasing and expanding range of procedures. In 2000, 2010, with the development of procedures such as EUS guided biliary drainages for the pancreatobiliary tree, another dimension was added to endoscopic management of pancreatobiliary problems. And that is how we find that continuing evolution and inclusion of newer and newer procedures in the range of ERCP and therapeutic endoscopic ultrasound are being added every year. In India, the first reports of ERCP or the first practice of ERCP began in the late 70s and early 80s at institutions in the north like PGI Chandigarh, where pioneers like Professor B.S. Anand, Professor Jung Delavri established this procedure and trained the current generation of senior endoscopists who have placed India on the world map as one of the leading places for advanced ERCP as well as for training for advanced ERCP in the world. At the All India Institute, Professor Rakesh Tandon, who did the first ERCPs in 1981-82 and established this procedure and has trained a very large number of endoscopists who are practicing in the Dr. B. Krishna Rao and other pioneers from Chennai also led the march of establishing ERCP in the southern part of our country. So I think I'll not take you through this detailed chart. Much of the material I am presenting to you has been taken from one of the very excellent textbooks on ERCP that Todd Barron and co-authors have published. The third edition came out a couple of years ago, and in there you can find how ERCP has evolved decade by decade as it enters its sixth decade, say if you trace it from 1970 onwards, and what have been the various landmarks is summarized in this slide. Now, what should be the layout? Before we start doing ERCPs, let us take a look at how the space should be arranged. Actually, as I said earlier, the setting up an ERCP service in an institution is an area in which a lot of work has been done, a lot of thought has been devoted, and it could form a topic for a 15-20 minute lecture in its own right. Here, briefly, the area that you are currently people say should be given for a therapeutic ERCP room is something like 500 to 550 square feet, in which dedicated areas and space should be given. And this entrance to the space, this is the ERCP table on which the patient is laid down. These days, with bariatric patients increasing, a standard table should be about 3 feet wide and should be able to take the weight of about a 150, 100 and 150 kilogram patient. At the head end, a large space is provided. In most places, you find that there is very little space left at the head end of the patient. This is the space dedicated for the anesthesia and sedation and nurse workspace, because today almost all procedures are therapeutic, and therapeutic procedures are prolonged. They require 40, 45 minutes, an hour or longer. And during this period, it is standard practice to do it under general anesthesia. So an anesthesia machine and at least a team of 2 anesthetists is required with the anesthesia cart at the head end, and correspondingly space needs to be provided. The C-arm or the radiology machine is positioned over the table, and monitors are generally now preferred to be placed on rails across the table so that the endoscopist has a straight view in front. And this is a monitor panel which contains the video endoscope view, the fluoroscopic view, and generally a third view, because often endoscopic ultrasound, or if spyglass is being done, cholangioscopy, or other ancillary procedures are done, which third monitor is required for the imaging. This is the endoscopist workspace and the endoscopic processor trolley and the boom that is placed, the scope is placed here. the first assistant and the second assistant, 2 assistants are generally considered essential for the procedure, and their workspace is shown here, while storage cabinets and countertop for working and preparation, etc. are shown. The same thing can be seen in standard references and textbooks in a live form, and in even you have YouTube videos which will tell you how this space ought to be organized. Generally, this is a busy space because a minimum of 8 to 10 people, endoscopist, 2 assistants, endoscopist assistant, anesthesia team, fluoroscopist, somebody to hold the mouth guard, and so on, are the minimum requisite complement of people who are there in this room at any given time. So a few general things now about that was the setting up of ERCP. Talk briefly about indications for ERCP. This again is taken from the same review that I mentioned, the textbook from Todd Barron, Kozarek, and Carlock. Briefly, among indications, we commonly now resort to one aspect is clear, that with the advent and the establishment of MRCP, other modalities for cross-sectional imaging and EUS, contrast enhanced and ultrasound, and so on, there is no place now for a diagnostic ERCP. ERCP is almost always a therapeutic procedure for biliary obstruction, with the appropriate drainage procedures being performed. They can also be done when for management of specific facets of pancreatic and biliary tract diseases like benign obstruction, stones, strictures, and other forms of obstruction. Whenever pancreatic malignancy is suspected, and for complete workup, and for biliary tract drainage, because biliary obstruction and a preoperative biliary drainage is an important indication. And in people with idiopathic pancreatitis, especially when conditions like pancreas divisum or other variations, annular pancreas are suspected, then there may be a place. Similarly, in patients with chronic pancreatitis and pseudocysts or pancreatic fluid collections. Sphincter of Oddi manometry is widely practiced in the United States, where sphincter of Oddi dyskinesia is a major indication. In Europe, Japan, and other parts of the world, and even in India, SOD, sphincter of Oddi dysfunction, and SOD manometry is done at very few centers. We had some experience initially at Lucknow, but patients being few and far between, and alternative management options being available, I think SO manometry is not widely practiced in our country. Some indications of sphincterotomy, CBD stones is a standard indication. Papillary stenosis or sphincter of Oddi dysfunction type 1 and type 2, where patient presents with biliary or pancreatic type pain. For placement of stents for drainage in dilated systems, obstructed systems. For the Sump syndrome, the Sump syndrome is refers to a situation in which the distal bile duct or a long cystic duct stump is left, and where it serves as a focus for stasis, often calculus formation and pain or cholangitis. Choledococele involving the major papilla, ampullary carcinoma, who is not a patient who is unresectable. And for access to the pancreatic duct, pancreatic endotherapy has now become a major area of procedures, and for pancreatic duct calculi in chronic pancreatitis, for pancreatic strictures, and IPMN, intrapancreatic mucinous neoplasms, their management, and so on. And placement of stents for benign and malignant biliary strictures, for fistulae, postoperative bile leaks, and in high-risk patients with very large stones who are high risk for surgery, often stent is done in left. So I'll not take you through each of these. These are different indications for which ERCPs have been performed and drainage is done. Ampulectomy for adenomatous neoplasms of the major papilla, especially benign adenomas, or if it can be established that a malignant tumor is not invading the wall of the duodenum, people have done an ampulectomy using a snare. Similarly, prior to cholangioscopy and pancreatoscopy, which is now done with the Spyglass. Earlier, there was the mother-baby scope. Now, 2 operator dependent Spyglass, a single operator used Spyglass is now available, and I'll briefly talk to it about in the subsequent slides. Contraindications are general. By and large, a careful balance between the benefit the procedure will confirm vis-a-vis the risk to the patient, and the risk or to the health or life of the patient have to be weighed. And in case the benefit is risk ratio is not favorable, that will constitute a contraindication to the procedure. Similarly, an uncooperative or an unwilling patient in the presence of a known or suspected perforated viscous upper GI perforation, there's an absolute contraindication to doing ERCP. And generally, situations where ERCP should be avoided is when for evaluation of obscure pain of unknown etiology, when you suspect sphincterocordial dyskinesia type 3 as a motility disorder, or some other episodes of pancreatitis is only vaguely suspected but not established objectively. This is not an indication for which ERCP ought to be done. Similarly, unless the bile duct is affected, so suspected gallbladder disease does not become an indication. And evaluation of a pancreatic malignancy or any malignancy of the biliopancreatic tree, ERCP is only indicated if it alters the management plan for the patient. If it is clear that this patient is a candidate for surgery, then there is no reason for undertaking an ERCP. Similarly, the lack of consent, again, the non-availability of suitable equipment or an adequately trained, competent person. Now, who is competent to do ERCP? What constitutes competence? All these things have been very well laid down, especially by the American Society of GI Endoscopy and the European Society of GI Endoscopy. And the SGEI, the Indian Society, is in a process of developing credentialing requirements, because with the increasing complexity, in the last slides, I'll refer to how one stratifies the level of difficulty of ERCPs and what is the level of training that is generally required to achieve competence in these procedures. So these credentialing requirements are increasingly becoming required, and with a lot of litigation and medical legal issues linked to this, it is important that if adequately trained or competent person is not available, or the suitable equipment and setup is not available, that would constitute a relative contraindication to the procedure. Similarly, an anticoagulated patient on antiplatelets, known to have allergies, non-availability of anesthesia, altered anatomy. For example, Billroth 2 gastrectomy results in altered anatomy, and which is a level 3, level 4 of difficulty. And unless a suitably competent endoscopist is available, that constitutes a contraindication. And except under very limited indications during an ongoing acute pancreatitis, acute biliary pancreatitis with cholangitis does constitute an indication for ERCP. But other than that, a presence of or suspicion of acute pancreatitis would constitute a contraindication to the procedure. Now, I'll quickly take you through some pictures which will give you an idea about the procedure. This is a diagrammatic representation of the upper GI tract, the C loop of the duodenum, down which the duodenoscope is passed. This is a side viewing instrument and not your standard end viewing instrument, which is used for diagnostic endoscopy. With this, it also has an elevator which is linked to the controls at the control section on the knob, and that allows accessories to be passed through the channel, and these accessories can be elevated and used to cannulate the duct of interest. Here this is, as you can see, the bile duct and the pancreatic duct and the pancreas, and these need to be cannulated. Now, to look at in detail with the normal anatomy of the papilla and normal papillary cannulation, this is the ampulla of Vater. The elevation, that is the major duodenal papilla. Up here you can see medial and proximal to it is the minor papilla, where the dorsal duct usually opens in the majority of patients. The common bile duct, this is the duodenal wall, and this is the intramural portion of the bile duct, which joins the intramural portion of the pancreatic duct, traversing through the duodenal wall to form the common channel. And this is within the ampulla. And you have muscles which are not shown here, which the sphincter ampullae, which forms the sphincter fibers around the ampulla, and sphincter fibers that have been identified by macrodissection around both the intramural portions of the biliary and the duodenal channels, which are called the sphincter choledocus and sphincter pancreaticus. So this is your standard normal anatomy and is present in about 90 to 95% of individuals. Variations in which separate openings of the bile duct and the pancreatic duct, etc., can be seen are present in up to 5 to 10% of individuals. So with the papillotome being advanced increasingly rather than the cannula, the papillotome is used for cannulation, and with manipulation and bowing, you engage the ampullary orifice. And once that is done, then here you need to manipulate the instrumentation by rotating the cannula, shortening or loosening the wire to achieve the cannulation of the biliary duct, which is the desired duct. Pancreatic ductal cannulation inadvertently happening repeatedly is an indication for prophylactic pancreatic duct stenting. But as we will see, post ERCP pancreatitis is a great problem and a bugbear for ERCP. So here you need to manipulate, a manipulation with these papillotome, where the cannula and the guide wire will allow biliary cannulation. In about 20 to 30%, there is a sharp inferior and downwards angulation of the bile duct before it straightens up into the supraduodenal portion. This is which makes standard cannulation difficult. Your wire will go up to a certain extent, but deep cannulation will not happen. And this then requires that the endoscope needs to be pulled back and position adjusted rather than the accessory being adjusted to achieve. You withdraw the scope and adjust position to achieve the desired duct cannulation. So this is a view of the papilla, and as you can see, this is a optimal position for the papilla. The papillary orifice can be seen here, and this is the intramural portion of the bile duct, which normally traverses at a 12 o'clock, 11 to 12 o'clock position from the major duodenal, major papillary orifice. And here, once you have the papillotome, you need to achieve a tucked under position, as though you are below the papilla and looking upwards towards the papilla, and align the papillotome guide wire and the intramural portion of the bile duct in roughly a straight line, as close to 180 degrees as you can get, to achieve desired duct, that is biliary duct cannulation. Another example, here you have an en face papilla. The scope is positioned that you are facing the papilla in front. The intramural portion of the bile duct is traversing this way. And this is a good position to attempt cannulation of the pancreatic duct. Now, difficult cannulations are a problem. You can have a very tiny orifice where the wire is not getting in, you're not achieving the desired duct, repeatedly going into the PD. So in this situation, people can actually place a 3 to 5 French stent in the pancreatic duct, and then approaching the bile duct orifice, which is roughly here above and to the outer side of the duodenal of the pancreatic orifice, you achieve a cannulation and subsequently a sphincterotomy, so that with the pancreatic stent assisted cannulation of the pancreatic of the biliary duct and a sphincterotomy can be done. Juxtapapillary diverticuli pose a particular problem. As you can see, this is a large diverticulum on both sides and the papilla is in between. This is the papilla. This is the orifice that you can see. And by pushing the papilla to one side, you can achieve a cannulation. And this is a long intramural duct portion, so that an adequate sphincterotomy can be done. Standard practice can be followed despite the presence of diverticuli. And that's the orifice and the intramural portion. Another situation where you have it in the edge, you can even have the papilla deeply seated in the pancreas and the pancreatic in the diverticulum. And for each of these, various measures have been described how you will achieve cannulation. Using the papillotome, rotating the papilla medially, and like you're using the papillotome to press and pull out the papilla from the edge. And this allows then cannulation. And with the straightening of the papillary orifices, the papilla is almost out of the diverticulum, although here it is facing inwards and at the edge. You can get it out of the diverticulum and do your sphincterotomy. Sphincterotomy is basically, we are using to talk about the accessories in a moment. This is the standard pull type Erlangen papillotome with, after you have engaged it in the A cut in the 11 o'clock to 12 o'clock direction is required for opening up the bile duct, which is what is being done here. Maybe I think this can also be shown here by the video, that you have gone into the orifice. You have to adjust the position of the scope and the papillotome, and you are watching under fluoro till you get your cannulation. The papillotome has now gone into the bile duct as confirmed by fluoroscopy, and the guide wire will then be passed deep into the bile duct. Some bile comes into the papillotome and you know you are in the bile duct. And thereafter, with positioning of the papillotome, 1/3 of the wire inside, 2/3 of the wire length outside, you tauten the papillotome, get your direction so that the cut goes between 11 o'clock and 12 o'clock, and you open up the bile duct. The limit to the bile duct opening is the so-called hooding fold that you see at the upper end here, which it is not sacrosanct, but is generally a good landmark to tell you about how far the sphincterotomy can be carried out. This is a situation in which a cannulation has been achieved, but the wire is pointing towards 3 o'clock. If you look at the papilla, this is the 12 o'clock direction, but your papillotome wire is pointing towards 3 o'clock. You're getting this cholangiogram. And so what you do is push in the scope, get a mid-long loop position, and change the tip so that you are now got the orientation at 12 o'clock and do your cut at the 12 o'clock position. Finally, difficult situations, you can do a needle knife sphincterotomy, a needle knife papillotome that has initially been done. It is done in layers. It decided the roof of the papilla is removed, and you have a, this is again a PD sphincter, which identifies the PD sphincter, and just above it, you have the opening of the bile duct. So once you've done you're not able to get the bile duct, a needle knife will de-roof the papilla, allow you to see the pancreatic duct and the bile duct separately. Then you get your biliary cannulation with the stent safeguarding the pancreatic duct and preventing repeat cannulation of the pancreatic duct and PEP. And this is how a needle knife is used. You work from below upwards and divide in layers to expose the layers and then de-roof the papilla. Now I'll just spend a few minutes talking about the bile duct stones, which are usually the commonest indications for therapeutic ERCP is CBD stone extraction. And some of the standard accessories used, this is your standard Erlangen type papillotome. When it is drawn tight or pulled taut, you can see the bowing. And as the wire is pulled, the bowing can be made more acute or less acute depending on the level of contact, direction, and type of the papilla you're dealing with. While this is a needle knife in which like an injector needle that comes out during sclerotherapy, you can protrude and advance the needle, and this can then be used to cut down on the papilla. Stone retrieval baskets of different types are available. Domia baskets, this is a wire-guided domia. And for biliary drainage, you have, this is your standard Christmas tree Tannenbaum stent with the large flaps which prevent migration and end holes for biliary drainage. And the standard double pigtail stent which has side holes in the pigtail that can be placed, where to use, what accessories. There are far more than accessories. During those of you who have attended the gym sessions with ISG, where the full 1 hour or 2 hours we take and still are not able to cover the entire range of accessories available for ERCP. So I'll not, other than the very basic ones we need for stone extraction, I have not touched upon other accessories. So this is the papilla. You have a bowed papillotome is being used to achieve cannulation by relaxing the bow, advancing the guide wire, you get guide wire up into the bile duct. This is without dye. Fluoroscopy can show by the direction of the wire that you are in the bile duct. Once you are in the bile duct, a cholangiogram is achieved and you can see there is a stone there. Sphincterotomy is done. This is not a complete sphincterotomy. This is maybe a partial sphincterotomy. The sphincterotomy can actually go up here, and the end point would be you can clearly see the common bile duct opening there, but this is adequate for the purpose. And in a domia under fluoroscopy, stone has been trapped and pulled out. There may be situations where extraction is not straightforward. For example, a square or irregular sized, irregular shaped stone, trapping and extraction becomes difficult, but using maneuvers like passing the accessories through the long loop and then shortening the loop of the scope from the long loop position to the short loop, You have a balloon extractor, which is being introduced. Balloon sweep is done with a cholangiogram and the stone is delivered. But then there may be these situations where your very large stones, 15, 20 millimeter stones are present in the bile duct, multiple stones, smaller one here and two very large stones, where standard procedures of sphincterotomy and dolmia extraction may be unsuccessful. And so endoscopic papillary large balloon dilatation is being something that is being tried in this situation for the difficult stone. A difficult stone is one that is more than 15 millimeters in diameter, maybe irregular in shape, generally present above a stricture, stones present in patient with a portal cavernoma cholangiopathy, intrahepatic calculi, Mirizi syndrome. All these constitute difficult bile duct stones, and all of which generally with a 90 to 95% success rate can be extracted by appropriate strategies of endoscopic stone retrieval. And the endoscopist armamentarium, apart from the dormia and the basket balloons that I've shown, include large balloon sphincteroplasty that I'll show you briefly, mechanical lithotripsy, extracorporeal shockwave lithotripsy can also be used in certain situations. And now using a spyglass cholangioscopy with laser lithotripsy or electrohydraulic lithotripsy has been used. These are controlled radial expansion balloons, 6 to 8, 8 to 10, 10 to 12, and 12 to 15 millimeter dilatation balloons that with a single balloon gives you more than 2 diameters and can be used to dilate the papilla. And this is an example of large stones in the bile duct, which is cannulated. A small sphincterotomy is done, and this is a 12 millimeter CRE balloon that is expanded over the wire, and you are then dilating the papillary orifice to give a nice opening. This is the appearance of the expanded balloon. And with these now, stones can be crushed, extracted, and it depends on how hard or soft they are. They may even be extracted after this, or they may need large balloon sphincteroplasty up to 15 to 18 millimeters. Selecting patients for this procedure that is shown here. Another example, in the presence of a diverticulum where a large cut is not possible, you can still achieve a dilatation, and this is the size of the opening after large balloon sphincteroplasty, with which using balloon extraction, stones can then be, this is the stone being extracted. So this is a quick video to show in a patient with diverticulum and papilla extending into the diverticulum. A small cut has been made. The patient has a very large stone, so this large balloon sphincteroplasty is being done. Balloon, this is a 12 to 15 millimeter CRE balloon. You can see the bile duct opening, lumen could be seen through the balloon up there, and once you have done it, then with the balloon extraction, you can see that through this large orifice, this very large stone has been comfortably extracted and delivered into the duodenum. That's the full size of the stone that has come out, and very large stones can thus be obtained by Ercp. Mechanical lithotripsy is another way with a very large basket, 5 centimeter basket, which can trap multiple stones, and with an extraction, with a handle that is attached outside, you can apply pressure and crush these stones, and the fragments then can be cleared by balloon extraction. Finally, at times a dormia gets trapped, and you have a stone in the dormia but can't get out, and you are stuck in the lower end of the papilla. For this rescue, we have the Sohindra lithotripter, which cut the dormia and pull out the wires, and over which the dormia, the sheath, metallic sheath is passed, and using this handle, you can tighten it. There are videos on YouTube which will show you in detail, and this needs to be easily seen, but everybody needs to learn this. Finally, I'll show you this last video on the spyglass laser lithotripsy, which we had been doing regularly at SGPGI since 2013 or so. And we have done over 50 patients with this procedure. So you have got the spyglass going up, and this is the stone. As you can see, a laser fiber is passed down the spyglass, and under vision, this laser fiber is firing laser energy on the stone, where pulverization of the stone and fragmentation happens. It becomes pulverized, literally powder that flows out. You need good biliary drainage, that is spyglass going in again. And here with the balloon, you can extract the fragments and thus Difficult stones can be cleared and the stent is placed to complete biliary drainage. I think another 5-10 minutes, Dr. Kapoor. So I'll talk to you briefly about adverse events in ERCP. While ERCP is an extremely versatile, very useful procedure, the number of competent ERCP practitioners is growing every year around the globe, but one needs to be cognizant of the adverse effects and the problems that accompany ERCP, to know about them and know about the ways an endoscopist can deal with them. In brief, and you can see that the mortality rates have ranged, and this is combined figures from large series, but 0.1 to 1% is a high mortality rate, and they have varied. And in fact, I think laparoscopic cholecystectomy and other procedures carry a much lower mortality rate. So one needs to bear it in mind that ERCP can never be taken lightly. It has to be done for very well-established indications and in very competent hands to minimize these. Series from very large and experienced centers, high volume centers, you have a mortality range that is below 0.1% or 0.1 to 0.2% in that range, while it may range to this or even higher numbers in smaller, lower volume centers. Significant adverse events that require prolongation of hospitalization can be severe, can be seen in up to 10%. Or even a larger number of patients. And these include pancreatitis. Post-ERCP pancreatitis is the most common and important complication. Average figure of 5% is quoted, but globally, if you look at figures, depending on the centers, the volumes, the level of experience, these and the procedure for which they are being done, this can range from 1 to 40%. In a person with previous pancreatitis or sphincter of Oddi spasm, or one undergoing sphincter of Oddi manometry, the risk can be as high as 20 to 40% of PEP, post-ERCP pancreatitis, has been reported. Bleeding following sphincterotomy can be seen in up to 0.1 to 2%. It can be major or minor bleeding with or without requirement for blood transfusion, but clinically significant bleeding requiring blood transfusions, prolongation of hospitalization, or use of a second modality like for achieving endoscopic hemostasis like angioembolization, hemoclipping, etc., is up to the tune of 0.1 to 2%. Perforations, there's a Stafford classification for perforations type 1 to type 4, can be seen in fewer than 1%. And other complications which are seen in fewer numbers are shown here. Now, what predicts these adverse events? One needs to identify that this will depend on definite suspicion of SOD increases the risk for pancreatitis. Cirrhotics will have higher complications, whatever you do, even if their integrity of coagulation is present. If a difficult cannulation is done, multiple passes are made, there's clear evidence of less than 5 to 10, more than 10 passes required to achieve biliary cannulation increases the risk of pancreatitis. The use of precuts in needle knife sphincterotomy, percutaneous biliary access, that is a rendezvous procedure, lower ERCP volumes are definite predictors for adverse events. Other features that may or may not predict, that may predict, are shown here. While these are others, Billroth 2 ampullary diverticulum, small CV diameter, etc., are not predictors for adverse events. What constitutes an adverse event? Terminology has changed. Earlier we used to call it complications. Now it is the consensus term is adverse events, or even more so, many endoscopists use the term unplanned events during ERCP. You are planning for a biliary drainage and then you experience an unplanned event. There has to be a consensus on what constitutes a complication and how to grade the severity of these complications. Martin Freeman, Peter Cotton and co-workers, 2009, the GI endoscopy paper is the standard bench of landmark that shows what constitutes mild, moderate, and severe grades of pancreatitis, bleeding, perforation, and infection. And you can always look it up at standard references. I don't think I'll go through these definitions in detail. Risk factors for adverse events for pancreatitis, we've already talked about these conditions. History of post-ERCP pancreatitis, pancreatic ductal wire passage, minor papillar sphincterotomy, balloon dilatation of the intact papilla. All these are risk factors for post-ERCP pancreatitis, while for bleeding, coagulopathy, anticoagulant use, cholangitis, cirrhosis, dilated bile duct, and again, low ERCP case volume have been found to be in multivariate analyses shown to be increased factors associated with increased risk of post-EPT bleeding. Now, post-EPT bleeding is not necessarily, can generally be handled, and one of the simple ways to deal with it, this is showing you that a sphincterotomy is being done, and right at the end of the cut, probably there is a vessel there, there is significant bleeding. Important thing is that you are doing the procedure for a purpose. Even if there is bleeding, it is worthwhile going ahead, placing the stent and achieving the biliary drainage. You come out with the bleeding without having drained, you have put the patient from the frying pan into the fire. This is adrenaline injections being done at the apex of the cut. Multiple injections and infiltrations are done. And in my experience, in about 80 to 85% of the times, with adequate infiltration of simple things like adrenaline saline, you can achieve hemostasis. Beyond that, hemostasis can be achieved with the use of hemoclips, or if they are large, significant bleeding, then covered metal stents can be placed, which will tamponade the bleeding vessel and achieve hemostasis. Finally, last couple of slides about what constitutes quality of endoscopy and ERCP. Pre-procedure, this is for all endoscopies, and these are quality indicators for ERCP. All these are now well-established procedures. Adequate literature is available, which is validated, and it is up to all endoscopists, endoscopy trainers, and training centers to familiarize themselves with what today is the minimum expectation in the quality of ERCP from a competent center. The American Society of GI Endoscopy has graded the complexity of ERCP procedures, because when you have complications and adverse events, it is important to know the context in which these procedures were done and what are the various levels of difficulty. So grade 1 and grade 2 difficulties, the level simple ones, selective deep cannulation and tissue sampling, and biliary stent removal or stent exchange are very basic minimum levels of competence, and anybody to be licensed to do ERCP has to be able to tackle procedures of grade 1 and grade 2 difficulty. Stone extraction, treatment of bile leaks, treatment of strictures, plastic or metal stents for benign strictures, and placement of prophylactic pancreatic stents whenever you are, because this is a well-established method for preventing post-ERCP pancreatitis. So these are level 1 and 2, and the basic endoscopist, basic competence in ERCP means capability of doing these procedures with an 80 to 85% success rate. And the volume of experience and all those are the other issues. Level 3 is extracting stones more than 10 millimeters, minor papilla cannulation in pancreas divisum and minor papilla sphincterotomy and stenting, removal of internally migrated biliary stents. The stents at times may migrate and their removal is a problem. The intraductal confocal laser endomicroscopy and other techniques, Spyglass would come in the intraductal imaging. Recurrent pancreatitis management, pancreatic stricture management, removal of pancreatic stones, treatment of hilar tumors when blocks, and treatment of benign biliary strictures at the hilum and above, sphincter of Oddi manometry, constitute level 3 of difficulty, and removal of migrated pancreatic stents is level 4. Intraductal therapy like photodynamic therapy, radiofrequency ablation therapy in the pancreatobiliary tree are level 4. Removal of pancreatic stones that are impacted or more than 5 millimeters, intrahepatic stones, pseudocyst drainage, and necrosectomy, ampulectomy. ERCP after a Whipple's or a Roux-en-Y bariatric surgery or a Billroth 2 gastrectomy would constitute level 4. And in case procedure is done after working hours in children less than 3 years and previously failed procedures with B2 anatomy, add 1 grade of difficulty. If you do this procedure in a person who is a child who is less than 3 years old, it will become a level 4 of difficulty. And this is how experience and competence from different centers can be then compared. Well, no time now for pancreatic endotherapy. Maybe at some point later we may cover this. And I think this is a must-see book. Peter Cotton's textbook for ERCP is what most residents follow and are familiar with. That's an excellent book for the beginners, but for detailed and to take you to where ERCP is today, this textbook by Peter Cotton, by Carlock, Kozarek, and Todd Barron is a must know for anybody interested in ERCP. Thank you very much for your attention.
Thank you, Dr. Saraswat. Yeah, questions, residents first.
You have mentioned that post-ripples ERCP.
Yeah. In patients with ripples, you may have problems at the epigastroma. You may have problems more often at the pancreatogenostomy that gets fractured, and the patient has pain. So, using the standard duodenoscope, going up the afferent loop, one can access the HJ and the PJ stoma. And after having access, treatment at that is difficult because it's a small remnant and it is difficult to get there. Increasingly now, people have even used enteroscopes, which are much longer to access if there are long redundant loops after the jejunostoma.
Yeah, so for example, if you have a bleed, post-PD, early bleed, intraluminal bleed, now we know that the two common sites of early intraluminal bleed, one is GJ, if it is a classical ripples, and other is the pancreatic stump. So an expert endoscopist can go from the stomach through the GJ proximally into the limb and reach up to the pancreatic stump. And if it is a cut surface which is bleeding, especially if you have done a dunking, because then the whole cut surface is seen inside the jejunum and can control the bleeding. And in fact, Dr. Saraswat has done that in one or two of our cases there.
So these are level 4 difficulties. These are not easily done and the failure rates would be high. But I think giving up because it's going to be difficult is not an idea. You have to try, do your very best, and if it doesn't fail, because the alternative is
the exploration for the patient. So, or angiembolization, whatever the surgery is.
And the other advantage is that you rule out a GJ bleed. See, as soon as you go, because GJ bleed is the easiest for the endoscopist to control. And we know that that is the commonest cause of early intraluminal bleed. So first you have to rule that out, because you don't want to explore a patient for a GJ bleed when you have an expert endoscopist available who can very easily control it without surgery. So the indication for endoscopy in early intraluminal bleed is one, to confirm or rule out or control GJ bleed, and then second, give it a try whether you can reach up to the pancreas, which will be difficult. So I have any student online wants to ask anything?
Is there a named vessel that bleeds?
named vessel that bleeds. Not really. I think when you go synchrotony and you're going up at the 12 o'clock, the larger vessels are generally thought to be more towards the 2 o'clock position. So one tends to avoid that while doing the synchrotony. Having said that, I think microdissection and the injection studies of the blood supply to the papilla have shown that they are supplied by the retroduodenal and retropancreatic artery, the supraduodenal artery, and also inferior pancreatic duodenal from the SMA. And there is a network of vessels. So I don't think it's a single vessel that bleeds. Earlier, there was a suggestion that why not do an endoscopic ultrasound, identify a potential bleeder and avoid it. But these strategies are not really proved fruitful in real life.
See, Shaswat, when we do pylorus preserving, you separate the first part of duodenum from the hair of the pancreas, and these pancreatoduodenal vessels are there. So from the arcade, which is formed by both superior and inferior pancreatoduodenal arteries, anterior and posterior. So there are 4 groups of vessels: superior, anterior and posterior, inferior, anterior and posterior. And they all run in this pancreatoduodenal groove and form an arcade. From the arcade, you get branches which go to the pancreas and to the duodenum. So one of these vessels will be going at the papilla also. And it is usually a small artery which is running in that fold of the papilla which bleeds, and which now, as Dr. Saraswat said, they can control by injecting adrenaline and clips and stents. Earlier, sometimes we used to operate, but I think in the last 10, 15 years, I think we have hardly had to operate on a patient for post-EPT bleed, because almost all the bleeds they can now control endoscopically. So there is a small artery, but once it gets opened with this cutting current, it bleeds.
One question about the current and they wanted to know. The energy source is monopolar cartridge.
Yes, by and large, so far, this we are using the Ercp 300D or the ESD 300 from Olympus, which Ercp gives you intermittent current. It's a newer technology in which it has a microchip which is able to sense the resistance in the tissue and adjust the current flow and the current contour to the resistance. So although you are pressing the pedal continuously, the current is passing intermittently and you are cutting in steps. Earlier days when we started, you used to have cut and coag or a blend. And with cut, you would simply zip through the tissue after initial resistance, while with coag, you get a lot of charring and a risk of inducing pancreatitis by producing edema at the pancreatic duct orifice and so on. With these newer electrocautery devices, I think the complications and these become less frequent.
One question from Professor. You told about the hoodie fold.
Yeah.
The limit of you can extend the that cut into the bile duct. Is there any? I mean, as a guideline, for the beginner or the distance from that where your guide wire has gone from the tip of the papilla to the distance.
See, I think actually this is something that is constantly evolving and changing about how much can you cut.
Yeah.
How much can you cut safely? How much you need to cut may not be the same.
Yeah.
How much you can cut safely will depend on the individual papilla. Papilla may be a small, flat flush with just the orifice seen and hardly any elevation, or it may be a big bulging papilla with a prominent infundibulum and intramural portion of the bile duct being visible through the wall. Now, that will direct your extent of cut. Say, in people with stones or people with ampullary tumors, you have intraductal, the intraluminal or intramural portion of the bile duct is bulging in completely into the duodenum. You have papilla that is 3 centimeters, 2.5 centimeters in size. The orifice is the same at the lower end, but what is it? The intramural portion of the bile duct bulging into the duodenum. Then you can cut above. So the papillotomy basically means cutting the papilla, and the papilla is the elevated portion of the ampulla that is seen in the duodenum, and that can be divided. Now, the flat portion beyond the hooding fold that should never be divided is not the case. See, I think several times we have divided and seen, and it depends. You have the cross-sectional anatomy with you. You know how much is the bile duct opening, and the intramural portion also is dilated. So I think at times you can cut beyond even the hooding fold, depending on the need. If there is a big stone and you feel you can get it out, then you might take the risk. So I think general guidelines are not to go beyond the hooding fold, not to do a complete sphincter papillotomy. Complete meaning the entire elevated portion is divided. But for example, when you do a large balloon sphincteroplasty, either with the intact papilla, then there is a bit of bleeding, or with a partially divided papilla, if you do, you are fairly safe, because the large balloon is opening up the bile duct to 10, 12, 15 millimeters. And if you have completely divided the papilla and only the duodenal wall remains, then there is a chance of causing a tear or a perforation in the duodenal wall. So all these considerations would guide you in deciding how long a cut you will make in a given patient.
One very basic question, and there's a very certain perspective we don't know. Why do we have to have a 30-degree scope without having why can't there be a scope which has both a front and a side facing scope, a camera? In the sense you have to integrate twice. Why is there something technical that we need to do? Because the side wing scope, it has its own issues of it having a lateral wall perforation. The front wing cannot do an Ercp. Why is it that there isn't an endoscope that just has both cameras like we have in surgery all the time?
Yeah, right.
Something that why would you need to integrate, put another endoscope in?
No, you don't need to. See, the question is that proper training is the key to avoid these problems. With duodenoscopy, side viewing approach, you can actually, if not 100%, you can get a complete view. You navigate from the pharynx to the papilla under vision. and that is by turning the tip upwards and getting the papilla to be looking instead of sideways, you can flex it so it is looking upwards. So I've known of centers and places where people, their upper GI scope went out of order and they were doing diagnostic endoscopies, managing varices, and doing a thorough job with a duodenoscope. Because with a duodenoscope, it needs a bit more manipulation and mobility, and the full view can be obtained. So in duodenoscopy and in ERCP, there is no place for a forward viewing scope. You only need a side viewing scope. The problem of duodenal perforation, the type 1 Stafford perforation, where generally it is a novice who is not aware of the technique of negotiating from the pylorus to the D2 across the D1, D2 bend, who or rarely mistakes diverticulum of the lateral wall as the normal human and pushes the scope through. So these are rarities. They happen in every center where there is high volumes and there are trainees, but that's a rarity. And that is once adequate exposure to, say, under supervision, number of procedures have been done, it is not a complication one encounters. So I don't think there is a need for dual cameras, unlike what you have in laparoscopic instrumentation. That's
one thing which I found when talking to students, that they are not clear about this difference between mother-baby and single operator. Can you elaborate on that?
Right. See, I mean, I think the mother-baby scope was developed by the Japanese in the 1990s, and in which it was a 2-operator scope. One endoscopist would negotiate and reach the papilla, and a floppy baby scope would be passed down the side channel of the endoscope, which is a 4.2 millimeter channel. And once it came out at the papilla, then intubating the papilla and doing cholangioscopy was under the control of a second endoscopist, because the baby scope also has its own controls. But while as a prototype and as a proof of concept for doing cholangioscopy, it was very good, but very fragile equipment and very cumbersome to use, because 2 people working together was not really practical. So the Boston Scientific with other engineers have developed this Spyglass, which is a single operator dependent thing. Once you have reached the papilla, the Spyglass, that is the cholangioscope, which is 10 French in diameter and has its own set of control knobs, is passed down the channel, and over a guide wire, you intubate the bile duct or the pancreatic duct, as the case may be, and get the spy scope down that. Thereafter, the scope can be strapped to the spy scope can be strapped to the parent scope, and its knobs and controls for right, left, up, down can be used to position and look at the intracholedochal lesions. And simultaneously, you also retain the ability to move the mother scope, that is the main scope, at the duodenum and change the angles and so on. So with the experience, people have got quite good at doing this. The optics of the baby scope was not great, but the heritage one is out now. The DS2 digital models have come up, which give you very nice views. They are now trying to develop image enhanced endoscopy, that is NBI, narrow band imaging and blue light imaging, etc., so that indeterminate strictures can be diagnosed in situ, as now is being done with image enhanced endoscopy and throughout the GI tract, where the typical whirl and pit patterns and the vascular patterns can be used to diagnose benign versus malignant with 90-95% confidence, just like a biopsy would. So those are the advances that are going on in this area.
So, but Spyglass is still a baby scope going through the mother scope.
Yes, it
Only
goes
difference
through.
is that the same person, same endoscopist can handle both.
Single user cholangioscopy is given the brand name of the Spyglass, and it is a separate scope, goes through the biopsy channel of like the baby scope.
So both the scopes have their own control knobs.
Yes.
So what is the? I still don't get that. What is
the 2 people is being manipulating because difficult.
One person can manipulate, single operator and dual operator. That remains the prime difference. And I guess the quality of the Spyglass, its stiffness and its mobility has improved. People, Japanese Olympus and other companies are trying to develop a dedicated cholangioscope, a 5mm scope, which you pass from the mouth and go straight to the bile duct. But I think that has not gained much popularity yet.
Any other? Anybody online? Any student online would like to ask anything? Okay, then I think we will close the session. Thank you, Dr. Saraswat. Thank you very much.